This video we will talk regarding the clinical features of glomus tumor. This glomus tumor occurs more commonly in females rather than males during 4th to 5th decade in presence with conductive hearing loss plus pulsatile tinnitus, which is a characteristic feature of glomus tumor. And when a patient presents with pulsatile tinnitus, we consider glomus as diagnosis until and unless proven. Here we are seeing a glomus jugular tumor in the floor of the middle ear. So this is the middle ear as medial wall of middle ear, and below lies the floor of the middle ear. So this glomus jugular, though slowly growing, later on perforates and arises from the jugular bulb and enter into the hypotympanum and then into mesotympanum. And as it is entering into the middle ear, it gives appearance of rising sun. Since it is highly vascularized, it appears red when we watch through the otoscope, and it looks, as we are seeing in this image, like a rising sun from the floor of the middle ear. So on examination, the first sign is the rising sun appearance or the red reflex. The second thing that we see is brown sign or pulsation sign. Now this is because with the Siegel speculum, when we apply the pressure in the external auditory canal and the middle ear, the tumor gets compressed and blanches. Okay, and when we release the pressure, the tumor again pulsates and the blanching is over. The third sign is Aquino sign. Now this is when we apply the pressure on the internal carotid artery. When we compress the internal carotid artery, there is blanching of this tumor. So we studied about three signs: the red reflex or the rising sun appearance, the pulsation sign, and the Aquino sign. This diagram shows the local invasion of a glomus tumor and the clinical features after the local invasion. So the first site of invasion is when this glomus tumor from the middle ear cavity perforates our tympanic membrane, okay, that we haven't shown, but if the tympanic membrane is perforated, it appears like a bleeding polyp, but we should be cautious not to avulge that bleeding polyp until and unless we have diagnosed the condition. Okay, so the first invasion is through the tympanic membrane laterally and leading to a bleeding polyp. Second can occur posteriorly via adductus or directly through perforation of the bone. It can enter the mastoid. Third is through the fallopian canal dehiscence or directly through erosion of the fallopian canal. It can lead to the facial nerve palsy. Medially, if this tumor goes in the inner ear, okay, so involving the labyrinth, it can lead to sensory neural hearing loss and vertigo. The fifth thing is if this tumor goes through the floor of the middle ear involving the jugular bulb plus, okay, plus it will lead to involvement of 9th, 10th and 11th cranial nerve, which will result in multiple cranial nerve palsies. Superiorly, this glomus tumor can invade into middle cranial fossa or posterior cranial fossa, and the patient will present with focal neurological deficit. So this is what we needed to know about clinical features of the condition glomus. Thank you.